So now we have to get to JW4 and 5. And the same thing, JW4 and 5 in males are more separate. Maintenant, le menton, c'est arrêté ou non? Let me see if it... Yeah, arrête. No, on attend. Any questions?
Yes, Maurizio, so that was beautifully demonstrated, but for the avoidance of doubt, can you talk us through how much of that was an anterograde and how much a retrograde ejection?
100% anterograde in C1. So why I'm moving, I mean, going up, injecting, going down, injecting, going up, injecting, because if you go and then you inject retrograde, you don't use the amazing lidocaine that we have in the products, you see? And the lidocaine effect, you saw, let me tell you how I trained myself with the speed. As I mentioned yesterday, I always take a look in the eyes of the patients if they do this look. It means painful, right? So I am injecting my hands, but I'm looking at the patient's eyes to see if they react, right?
Perfect.
So that means every patient has a speed. There are patients that they feel 0, then I can go faster. But if I feel that the patient is sensitive, I go slower. And if they are uber sensitive, I go even slower, you see? So we respect the patient's speed. And I tell my patients, I always tell my patients, my friends, that pain is speed with Vycross, because we don't expect the patient to feel pain, right? This is the third patient that you're seeing, and they are not reacting. Okay? If they react, it's because of me. Un petit peu plus, ça marche pour vous? Now we mark. Take a look, JW4 and a JW5 also apart the midline. And remember, JW5 is under C2. Maintenant, c'est la même injection. So we clean, clean, clean. Paint strongly. Clean again. Circular movement. Start injecting anterograde. Remember, yes, the 02, 02, 01. I'm not marking because you know, but before I used to mark all the time. So 05, cotton-tige. So controlling all the time. Ça fait mal, hein? Non. Tournez la tête. So clean, clean, clean. Paint strongly, clean again. Needling, circular movement. Always, we have to be with our fingers far away from the cannula. This is a big difference that I see from Voluma and Volux. You know, before with Voluma, sometimes I saw the product spreading, which is desirable for the cheek, but not for the jawline. Ça fait mal, hein? Okay, 05. Now another 0.5. I don't know if you remember, take a look, the dimple each time more visible.
Absolutely.
So now, remember that after we finish the chin, I make the dimple excessive because after the time, it will not be so excessive, you know? It reduces. It will not be so dramatically dimpled as I see here. If you remember, when I finish the chin, I have to go from backwards, right? Posteriorly assessment from the top. And I massage to make sure, relaxer la bouche. Salina. We have to make sure that the chin and the projection that we have is even. Where's my flip chart? The new one. Can somebody tell me what I have to do now? Selfie.
So let me go to the other side to be fair for everyone. So, who wants a selfie? Okay. Here. Gentlemen.
Sorry.
Please introduce yourself. Thank you.
Yes, good afternoon. My name is Aldo Rendon from Mexico.
Hola,
The-
hombre. ¿Cómo
Thank you.
estás?
Fine, thank you. Our next code is JW2.
So, okay. How I inject it.
Okay, with Volux in a subcutaneous layer with cannula, fanning. The active number is 0.5.
Hombre, eres fenomenal.
Gracias.
Pero, now, what's the next one?
Okay, the next one is C5 for the second time. No, for the first time.
Yes, how should I inject it?
With Volux in the subcutaneous layer. No, sorry, in the supraperiosteal layer with a needle in a bolus of 0.3.
Yes, and then you know that I have 0.2 left. What should I do?
In C2, also Volux in a supraperiosteal layer with needle in a bolus of 0.2.
Brilliant, hombre. Gracias.
Gracias.
I didn't know we had people from Mexico here.
It's a big group here.
No, really?
Big Mexican group.
I didn't know that. Amazing. Okay, so now, as my friend from Mexico said, I have to inject JW2. Take a look how nice we can see already the angle. So, this is the moment where we draw. It's a line, it's like C2. Sorry, it's like C1 that we do. And we enter and we fan. Let me tell you, you say, Mauricio, why don't you do linear? Because as well, if we do linear, we don't lift as much. And Volux is very, very cohesive. If we leave a line, a sausage, it will become visible over the time. So that's why making a little fanning is better. It here should not be painful, but I would say this is challenging to progress because the skin is very tight. This is more movable, and here is tight. So clean, clean, clean. Paint strongly. Clean again. Needle in. Circular movement. And then we enter. So for creating a ramus, Volux fits perfectly well. The performance of it, right, by creating, it's just like creating a solid bone here, you know? We have here 0.5. And we clean the marks. Let me see how am I going to show this to you. Take a look.
Great.
Take a look. This is nice because now it becomes very straighter. Look.
Nice.
I don't know if it's visible from this. It becomes really, really powerful. L'autre côté. Ça fait mal, vous me dites. Hein? This region is not so sensitive. Monsieur, comme ça. Si c'est possible. Hein? In this, we can see nicely the dimple, we can see nicely the contour of the jawline. Clean, clean, clean. Bend strongly clean again. Needling, circular movement. And fanning in the so we have to be careful. Cannula here, my friends, is very important because in the subcutaneous, I don't know if you remember, we have the superficial temporal artery here. Okay, so don't do needles in JW2 here. Yeah, can you repeat that, Mustafa or Nestor? Because guys, some people may say, okay, I'll try with needles. JW2, in the sub-Q, we have the superficial temporal artery, yeah?
Absolutely.
Yeah, so this is an area of attention.
Absolute danger area,
Yeah.
so always use the cannula
Sure.
in JW2.
Now we are going to C2, C5, starting with C2. Stop. Done. Okay. Can you please show... Yes, Chin, look at me. We start with C5, right? Look. C5 is more lateral. Take a look. And C2 is already where we have injected into the subcutaneous. And we escape the dimple. Look at me. And let me tell you this, my friends. I don't know if you know this. Volux, people will feel more tenderness, harder when we have bolus than when we have fanning. So this is an area that they are more likely to feel the product. Sit up. Comme ça. C'est bien pour vous? Fermez les yeux.
Please do not take photos and videos.
Clean, clean, clean. Cotton tissue. This area bleeds, okay, usually, when we do needles. We pinch, touch the bone, aspirate, and we inject 0.3. Okay. Now we go to C2. Non, ne change pas. It's, yeah, we lose a little bit. It's okay. So, clean again. Cotton tissue. No. Au milieu. To create even more the dimple. Clean again. Zoom in. Don't go through the marking, never. Huh? We have 0.5. We go to the other side, ne change pas. We don't need to change the needle. only when I feel that's not cutting anymore, because sometimes we lose a little bit of the product. So clean, clean, clean. Coton-tige, pour vous. Hein? Sorry. Touch the bone, aspirate. You clean for me, okay? Sit-tu. Rapidement. Yeah. Aspirate. Coton-tige. Coton-tige, ici. You know, if we don't put the cotton tip, and it will invade the midline. You see that time by time, it's becoming really, really structured, the chin, in a very different dimensions. Remember that I changed now, I was going to do this, then we're going to do C6, right? To finish the chin area.
Very nice how it
Yeah.
becomes chiseled, his chin and
Yeah.
jawline.
He's becoming very, very nice and chiseled. So let me tell you, C6, stop the bleeding. C6 is an area, my friends, that is amazing for marionette, but it widens the face, you see? So be careful with females. Fermez les yeux. What is C6? Is the lateral chin, right? Only for you to have an idea of proximity. The base of C6 is JW4. So this is a triangle whose base is JW4, which is under. So whenever I have challenging marionette lines, I work with C6. But for females, we have to increase more the zygomatic width. So this will make his face much larger, which is very, very masculine. Est-ce que vous pouvez, s'il vous plaît, c'est comme ça. Also, C6 with Volux is challenging like C1. So, hair follicles. Clean, clean, clean. In strongly. Clean again. Needling, circular movement. This is not part of the 9-point shape, okay? And the reason I didn't include it is because this is an exception. Only when you want to widen, make the face even squarer. I also have a rule in my mind, right? So this is the triangle, right? I divide into 3, okay? So what we have, 0.5. I don't want too much in the upper. I don't want too much in the middle, otherwise this is going to be too superficial and move. So if I have 0.5, I put 0.3 under, 0.1, 0.1, okay? Because this is a larger area. If I accumulate a lot in the middle part, the patient bulges when they speak. So we have Volux in C6. And here I have to do also intraoral massage afterwards. Rotate. Good. Vers le haut. Yeah, ça c'est parfait, monsieur. I think I will try to hand. So I have a good entry point. I will see if I can do from JW4. C'est déjà là? J'ai déjà là? I will try to enter. If I don't, yes. If it's already open, remember 03 down. Si ça fait mal, vous me dites. I tell you, even with Volux, which is a more robust product, we have really to practice, you know, to not to lead to any irregularity. Monsieur? You see, getting stronger and stronger.
Right.
Nice, you see? And you see something nice, he's getting a little bit sunken here, which gives this kind of chiseled appearance. Now what we are going to do, we are going to work on his periorbital area, his jawline, everything, no double chin, everything is very, very strong. We are going to go with CK3. Fermez les yeux. Non, les yeux vers le haut. Non, non. Okay. Non, comme ça, non. OK. Straight, OK. Vers le haut. So, OK. Marking. Let me tell you something about male patients in CK3, right, guys? We have to, fermez les yeux. We have to be careful not to overproject. I will tell you something that is very nice. When I inject CK3, deep malar fat pad, he's going to be even more sunken here. It's going to be really nice, okay? So, but we cannot concentrate. What I do a very wide CK5, a very wide CK3, very wide, okay? We don't want to see any projection. And always remember that we have the mid-pupillary line. Ouvrez les yeux. And where we have the infraorbital foramen. Fermez les yeux. So, put your finger here, yeah, c'est mieux. Remember that I always remove the marks to avoid any contamination. And be careful, I cannot project. So if I cannot project, I will divide usually in a wider area that I would do for females. Pinch strongly, clean again and again. Needling. Clean. That's okay. Si ça fait mal, vous me dites. So I go towards the bone. I touch the bone now, guys. I felt it. Now I'm starting going laterally. I go across the zygomatic ligament. Very gently. In a very wide, and this is sensitive as well. Very slowly. I'm almost rasping the bone. Okay, I'm going to show you to see what CK3. Can you le menton vers le haut? Okay, you see that there is no overprojection. Is it visible there?
It is.
So I don't want to project. That's why I did the fanning in a huge area. Asseyez-vous. But take a look how he's becoming more chiseled.
Nice, and also the improvement of his lower eyelid.
Yeah. And also, you see, the concavity will work nicely. So listen, we program for this session CK3 here, okay? So let me stop the bleeding. The secret is no projection. Toi? Clean, clean, clean. Pinch strongly. Clean again. Fermez la bouche. Needle in. Circular movement. Change the gloves. No, you have to. Sorry, we have to change now the cannula. Excusez-moi, un moment. So if we have any perception of contamination, we have to change. So when I go through the ligament, this is difficult. I'm having difficulty here, the zygomatic ligament. Difficult to go through. Look, resistance. Now it's go, done. I always protect the eye. Si ça fait mal, vous me dites. Very gently. Now, after injecting CK3, we finish session number 3, right?
Right. We're done.
We have already a lot of selfies, or should I ask for another one?
Someone wants another selfie? Yes, they want another selfie.
So tell me what I should do now.
What's the next step? Let me go.
There are lots
last
of
row.
there are a lot of codes now. Huh?
So, from this road, someone?
No, pas.
Anyone?
Over
Oh,
here.
there.
You know, listen, what happened yesterday, many people stayed for selfie. Today, no, it's only the people I wrote their names that they really answer the questions.
Perfect. Please introduce yourself.
Hello, my name is Ivan Ozuno from Sofia, Bulgaria.
Okay?
I think we shall proceed with Volift CK3, cannula, fanning,
But what's the layer?
SUV,
Okay, and what's the active number?
0.5.
Now
each side.
I have a difficult question for you. Do you know the entry point for CK3, Mailer Fat Pad and SUV? The entry point is the same, correct?
Yes.
How do I know I am in the deep Mailer Fat Pad, and how do I know I am in the SUV?
The angle of the cannula. Yeah.
Stop. That's it. So what should I do with the cannula to be sure that I am in the Mailer Fat Pad? The angle
Touch the
is-
bone.
I know, but the angle is more perpendicular for the Mailer Fat Pad or more parallel?
More perpendicular.
Yes. So we enter towards the bone, and then we tilt, then we fan deep. And for the SUV, more parallel. Only because of this, you got yourself already. Okay?
Perfect.
Thank you.
you.
Now let's go, and let's go to the SUV area. So marking. The difference between the Mailer Fat Pad, larger, and the SUV is higher and more superficial. Okay? And we get the same, we get the same entry point. So clean, clean, clean. Bow lift. Clean again. Yeah. We have to be sure where it's the yes, again. Good. Remember that because of the skin close to the nose is thinner, this is where I inject less. I'm pointing the cannula towards the surface, but we don't see it. Ça fait mal, vous me dites. So like 0202, and we do a 01 medially. Always to avoid the vein congestion. Okay. After, we go to TT1, TT2, TT3. Sit up, sir. We massage. Ferme les yeux. And we go to TT1, TT2, TT3. Ouvre les yeux. Where we inject with micro-aliquots. Ferme les yeux. So 0.2. Ça fait mal, vous me dites. Hein? I will have to massage him after off camera, okay, my friends, because he has no coverage. .5. So, my friends, I have a lot of police officers here. They are asking me to not to procrastinate too much, but I will do the massage afterwards, okay, my friends? I have to massage C6 intraorally. Rotate. Now let's go to the SUF. Clean, clean, clean. Clean again. It's more superficial, but still under the muscle. And the muscle is very superficial already. Ça fait mal, vous me dites? Now, massaging. Marking the tear trough. 1, 2, and 3. Clean, clean, clean. Now I rasp the bone. So 02, 02 again. tau 0.1. Okay? So, EMLA. Yeah, I'm going to put a little bit EMLA in his lips because he's a man. Monsieur, regardez-moi, comme ça. Roulez les lèvres. Comme ça. Roulez plus les lèvres. Okay. We're going to do the nasolabial folds. I have to massage afterwards, okay? So clean, clean, clean. No, let's go without marking now. They know. So 0, I start with NO2 to reduce the pain. So I go 0.2 and then 0.3. This is to improve the dynamic nasolabial folds. Clean, clean, clean. Sorry. Okay. 0.2. Ça fait mal, vous me dites. Clean, clean, clean. Sorry. And then 0.3. So while I wait a little bit here, I will massage, I need to massage already, okay? The cheek, give me the, no, yeah, Salina. Any questions?
Maurizio, you had promised us yesterday to show us the microaliquots of TT1, 2, and 3, but I appreciate in the interest of time,
I
we
think,
can maybe see the next
I think,
one.
we have to do in the next one. No, yeah, it's either this or I show the lips. What do you guys prefer?
Unanimously lips.
No, you didn't ask anybody.
Oh, they've been shouting.
Okay, good. So get me a cotton tip. Monsieur, maintenant c'est les lèvres.
Okay, if you have any questions, just write it in the app, please. And no filming. Respect the privacy of the patients.
Okay? Relaxez la bouche un petit peu. You know, the time that I have from EMLA is 0, right? But at least it's psychological. So, relaxez la bouche. So, clean, clean, clean. Pique maintenant. Excusez-moi. I know. No, sorry, I have to purge here. Hold for me. Give me again. Yeah, I have to put. With the hair, sometimes it's really tough to find the orifice. I know. Relax. Ooh. We open it lightly, the mouth. 0.2. I know. Zero point 0.2. Zero point 0.3. Ça fait beaucoup mal? Hein? Ça va? OK. On va de l'autre côté. On est presque fini. C'est la dernière chose, OK? Clean, clean, clean. Paint strongly, clean again. Pick. Excusez-moi. Oui, je sais. Ouvrez la bouche un petit peu. OK, j'attends. So 0.2. I know, sorry. OK, c'est bon. OK, excusez-moi. Give me sterile for me to clean. This is sterile. Yeah, I don't like to touch, we cannot touch the camera, but I don't like to see bleeding. It's almost finished, okay? Okay, relax. Zero point 0.2. Done. You did it. Félicitations. Now, let me lower the bed to massage. Saline. Okay. This is going to be bruised in this side. Remember, we ask the patient, ouvre la bouche, massage. My patient, he needs glasses to see, okay? It's okay for you? What do you want? Ah, okay. No, regardez. It's okay? Okay. Pour parler. Masser. I will do now an intraoral, ouvre la bouche, in C6, very important. In another way, regardez-moi, roulez les lèvres aussi. Oui. Continue, je sais que c'est presque impossible. Maintenant, dites-moi avec la langue si vous pouvez sentir quelques produits. Non? OK, parfait. Saline? My patients will have to wear glasses, okay, to see the result. Okay, Nestor, and Mustafa.
Okay.
Now, we are going to see, can I see the before photo? Attends, c'est bon. Eugenia, pas encore. Can you look in the camera for this a little bit? Okay, relaxez, relaxez. Ne bouge pas. Pas de sourire. Comme ça. Freeze. Now I'm going to make him wear glasses to see the photo. You can show. You can show.
Wow, amazing.
Okay, now unfreeze.
Okay.
Where can you see, où est-ce que vous pouvez voir la différence?
Déjà au niveau de cette zone-là.
OK.
Le menton, clairement.
Le menton.
Ouais.
So he said the jawline, the chin, que plus?
Les pommettes, clairement.
The cheeks. Anything else?
And the lips.
And the lips. Now,
Just a bit.
OK. Qu'est-ce que vous avez préféré? What did you like the most and why?
Je dirais l'ovale du visage. Parce que,
So he said the jawline. Why?
parce que ça me rend plus masculin, je dirais.
Because he has, he sees himself more masculine. Okay. Now, we are going to now explain about Volux. Okay. So we give alcohol for the patient. So he's going to do disinfection. Si vous voulez, vous pouvez utiliser le net. Okay. Now he cleans with alcohol, and I ask him, est-ce que vous pouvez toucher le pommette?
Oui.
Est-ce que vous pouvez sentir le produit ou non?
Non, ça va.
Non.
Non, non.
OK? Et ici, dans le menton, est-ce que vous pouvez sentir le produit? Oui ou non?
Non.
Plus haut? Oui ou non? Non. Louder? Can you say more?
Non, 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 je sens rien.
Non.
Non, non.
Et ici, est-ce que vous pouvez sentir le produit?
Là, oui. Un petit.
OK.
Oui.
Et ici, dans la bouche?
Non.
Non. OK. C'est très important pour vous. Demande cette région ici, touche.
OK.
Ça, c'est... this will be hard as a stone. Ça sera tendu. OK? Et ferait un petit peu mal. OK? So maintenant, c'est soft. OK?
C'est souple.
Souple. C'est souple. OK? Now, try to drink a little bit water.
Une gorgée.
In God. Possible?
Oui, totalement.
Regardez la caméra et dis bye-bye. Excellent.
Amazing.
So I suspect
Later on.
later on after lunch, Maurizio, will you be joining us on stage or can we excuse them?
It was also very nice to see the improvement, really. Step
Was it
by
the
step.
bit? Yeah.
Yeah.
Thank you. So, did you see immediately after how natural he looked? Even with a big smile, you know? So we had like 4 syringes, Volux, 5, C6, 7, 8. And he was able to talk, he was able to drink, and you saw he gave a big smile, no distortion. I don't think it's possible to do this with any other technique and product, believe me. Because this is what we have as a natural result and the physical properties of the product. As I tell you, when we put 1 syringe, 2 syringes, 3 syringes, we had like 16 syringes with him. So we had also syringes in his cheeks, right? So all the muscles are affected. I don't know if you know, to make the side, I had a question yesterday, very nice, of one of the people here, they told me, Mauricio, can you ask Mauricio, please, that I always inject from the right side, and my right side is always better than the left? Who asked this question? Me too. Always, I tell you. But it's something that we have to try to work on. And have you noticed that everybody is asymmetrical? Do you agree? Did you notice that I injected the very same volume? So I don't mind neurotic symmetry. It doesn't matter. Unless the symmetry downgrades the grading of the patient. If I say, oh my, the patient is ugly because of the asymmetry, then we have to address. If not, you can put the very, very, very same quantity. What is important, as I mentioned you, is there are, you know how many muscles we have around the mouth, right? To articulate. It's a lot. Right side, left side, elevators and depressors, besides the orbicularis oris. If you don't get in the correct plane, for example, the right side you put in one plane and the left you put a little bit, you will distort. So that's why practicing with one, I tell you, really, start with 1 syringe, then you go to 2 syringes, and always testing, kiss, smile, drinking, for you to see that sooner or later, this is going to happen. I think some of you will immediately, by injecting correctly, being aware the correct layer, and using, of course, Vycross, you're going to see how wonderful your results can be, okay? I know we are late. We cannot stop. The next case is harder, right? But we are going to go, can we go and come back faster this time?
1:30.
You have 25 minutes. Bye-bye. Ciao amici. Hello people. This is a are you enjoying the speed? We should this 1 week without rest. Like 10 hours of crazy work. So my friends, you know what we are going to start now. The team prepared the videos from the patients yesterday and the before and afters for you to have an idea about their looks. And then we go to case number 4 of the day. Let's put it there, please. The flashback from yesterday. I want to also see from here. Oops. Eugenia, can you put, please, no lights and only 2 screens? So we have her, 26 years old, right? Tired look, sad look. No. Go back, Eugenia. Only 2 screens. You see, the problems that we had here, it was her eyes, right? So she wanted her lip that we treated, her tear troughs and eyebrows that we didn't do anything. So the clicker, and then she wanted her jawline, her lips and tear troughs. We did not touch the jawline. You know why? Because if we do her CK1 curve, we may have an improvement of the jawline. Okay? So in the mirror, she wanted to look less tired, more attractive, and more contoured, meaning 1 reality and 2 dreams, and less tired, less saggy, and less sad. And let's remember can you remember the codes with me? Let's try to talk them, speak them. Everybody, loud. Let's go. My patient is 26 years old. CK1. CK1, malar fat pad, deep. Ah, yeah, CK3, correct. Yes, you deserve a selfie. I was testing you. CK3 soup, now TT1, TT2, TT3. So, CK1, CK3, malar fat pad, and CK3, SUF. Always more superficial, higher. This is the difference. Angle is important. Then we did TT1, 2, and 3. Then NL1 and NL2 because of dynamic nasolabial fold. She doesn't have the line, so I do sub-Q with cannula. And the lip this time, we only showed cannula to show the technique 02, 02, 01. LP1, LP1, LP6. So no distortion, doing well, okay? So here, before and after, we see the improvement of her eyes. We see thicker and bigger mouth. Take a look. Take a look, something interesting. When she kisses, that's why, my friend, as I always tell everybody, so if somebody has perioral lines, we don't start in the perioral, never, because you can flatten the lips. Take a look. So by making the lips fuller, when the patient kisses, they reduce the perioral line. So if I have somebody with perioral lines, I go with cannula first, and I only go, then after I go to the lip framing, and after I go to the perioral lines. Starting with the perioral lines can make the lip flatter and wider, longer. They look older. Okay? Now, take a look when she tilts down, right? Because when the patient tilts down, we see more the eyes. Take a look. And you see how the shape of the face lifted. So this is why it's so important to anchor in CK1 and also in CK3. Although, that's why I never promise dark circles, right? Dark circles are color, but we see that it improves, but I never promise. I say, so I can improve the concavity, but if the dark circles become lighter, it's a bonus, not a promise. But they do get better, okay? But I would not indicate to say, okay, come here only to make the dark circles brighter. You see? No, we have to indicate for concavity. And if it makes it brighter, it's a bonus.
Hello?
Now, take a look, the oblique view of her. You see? So this is how people will see her. So with less tired, fuller lips. Nobody can tell that she was injected, which is nicer. And let me share this. Remember that she had only this tiny double chin, right? We didn't treat. Now you're going to see why. Take a look. So why this is already corrected? Only because of CK1 top model look. So when I have a minimal, we can already correct. And take a look at the projection of the lip. You see, now we have the lower lip, the upper lip, not looking too much projected in the full profile, showing that we're bringing balance. So we improve the dark circles, we improve the neck, right, submental, without big projection and without addressing it. So we had 6 syringes for her, and I tell you, we could do 4 only if we reduced, let me give an example, if we reduced like something, but it wouldn't be so good, you know, it wouldn't. But it's a possibility. This case was really challenging. Remember, 36 years old, really challenging. I think she was much more challenging than the male patient today in the morning. This requires more assessment skill, and it requires more technical skills as well, okay? Now, she wanted her eyebrow, double chin and lip. That's why she has this tattoo, which is very difficult to fix now, because I don't know if she put this higher to compensate that it was lowered. So that's why tattoo in the eyebrows are tricky, you know, because over the years they change. So in the photo, she wanted jawline, eyebrow again, and tear trough, right? Now she wanted in the mirror more contoured, less saggy and less sad. And here she wanted less tired, less sad, less saggy, because I have forced her to look at the realities, to clean the house. Let's remove what is wrong first, and then we go to the dreams, right? Let's see her piano video. Oops. My patient is 36 years old. So we started with CK1 anchor, 0.1, 0.1, 0.1 bone. CK4 subcutaneous. Then we did first JW1 bone to give projection, and then sub-Q for lifting. So these are the lateral vectors, CK1, CK4, and JW1. You see that we do not put here if we have 0.7, right? So JW1, here, wide big triangle for lifting, C1 and C2, close to the midline. Take a look, up, down, up, down, up, down, up, down. You see? So when it's faster, we really see the movement of the hand. Oh. Up, down, up, down, up, down, up, down. I like the piano because it shows how we have to inject C1, C2, JW4 and 5, 02, 02, 01, and 025, 025. Remember that because of her double chin, we have to repeat double the dose. You see, this is the same technique I used in the male patient, right? It's the same codes. So this was T1, right and left. Yeah, to try, but it isn't. It's, you know, it's the tattoo. Oh, remember the angry dog? So here is the SUF, and we have to be careful to get closer to the nose, because if she smiles, this can look worse. That's why I fear the angry dog. Now TT 1, 2, and 3, 0, 2, 0, 2, 0, 1, both sides. And then we have NL1, NL2 first to reduce the pain, and then I go to NL1, okay? LP1 upper, 0, 2, LP1 lower, 0, 2, LP6. Look, 0, 2, 0, 2, 0.1. Again, 2 syringes for her. And she's drinking water. Yeah, that's a beautiful case, yeah? Yeah. Now, let us see her photos. Oh, Pete, Eugenia, can you remove these lines? I forgot, please. Pete, we have to see the lines after. Is it possible, guys, to, yeah. You see, nice, huh? Yeah. This case was nice. You see, sometimes, if we have a complex case and we end up by injecting, right? Remember, for her it was 16 syringes, right? But for her, we did her maximum treatment with everything that was possible. We tried to fix in that session, okay? So we did foundation mid-face, and then we went contour lower face. We did the periorbital lips, 2 syringes, which is really impactful. You see, if you put, that's why I will not compare Vollift with any other product from other company, but I would like to compare Vollift with Juvederm 2-3, you know, or Ultra Plus. If I put 2 syringes, they wouldn't be like that, you know, easy to move. I think Vicross for animation has something, you know, that is superior. When I say is the performance that we see, not only in duration, but in natural facial expression. This is really clicked. Can you, okay, it's here. Now take a look. You see, let's put the lights down. You see the change of the shape of the face, right? We notice a very important improvement. She continues to be round. It's herself, right? But you see, we do not see anymore the double chin, and we see also the width and the length, right, that she has for the lips. And very natural. I look at her, I don't think that she has been treated. This is nice, right? So there are many people that they don't want anybody to know. And take a look at the JW1, the effect that we have. And you see, although people would look at this and say, Mauricio, she desperately needs JW3. But take a look, I didn't. That's what I learned over the years. Because you stretch CK1, CK4, JW1, and you project JW4 and 5, JW3 solves by itself. If it doesn't solve, then I reinject. Then I spend 1 ml more. Okay? These are learning, right, guys? I'm learning over the years. Okay? So take a look what happens with double chin and smiling. Also take a look. You see that when she smiled, she had a very even activating her platysma. You see, but now we see less concavity. We see also less, take a look, the DLI, the depressor labii inferioris with C1 is corrected, right? And you see also the mentalis here. We see all the improvement. And she continues, yes, you know, having a folding because this is hers, right? But you see that it's more pleasant to look at her smiling after the treatment than before, right? It's more pleasant. So we see changes in the cheek and changes in the mandible angle and also the neck. You see double chin. Take a look at the kissing. Take a look how many syringes here. We had 4 plus 2, twice, 6. 7, 8, 9, 10 syringes, right, guys? Remember. So C1, C2, JW4, 5, 4. Then I repeated JW4 and 5, 6. Then I did 1 ml for nasolabial fold, 7. Then I did 2 ml for lips, 9, right? We're talking here 9 syringes. Take a look. So you see, we don't see anymore the double chin, and the patient is able to do the movement without distortion. And take a look again, the perioral lines. So we see really changes all the time. Take a look at the baby cry. When she does the baby cry, we see the wrinkling, we see the eversion of the lower lip, we see the jowling, we see the double chin. Take a look after. You see, more coordinated. That's what I tell you guys, 9 syringes, and she's able to do the movement, right, normally. Now, let's observe her, looking down. Many people ask me, Mauricio, she needs chin. Why don't I start only with the chin? Because imagine, she's heavy. If we don't lift her cheek, she's gonna have, take a look at the shape now. You see? So if I had only done the chin and double chin without the cheek, she would be heavy here. And take a look, this, guys, this is why I think volume is powerful. If I had injected like Juvederm or even like 2, 3, or 4, whatever, it does not lift. You see, it's Voluma that's lifting a lot, and also Volux, making the patient, every time that we put our face down, our face collapses. That's why I think getting, and you see, she looks slimmer, doesn't she? It's incredible, incredible. Take a look at the lips also, and the nasolabial fold. You see, I didn't treat her marionette lines, right? And even though, you know, it's good, it's good. Take a look. This is how people see her. She sees herself in the mirror, frontal, and this is how people look at her. Take a look. So the coordination that we have, take a look at the definition of JW3. So the lips, even her nose looks less dominant, you know, because the cheek now are fuller. She looks more balanced. Take a look at the jowling. Now, the difficult part, okay? So you see that the skin excess that she presents here, almost 100%, almost. So let's suppose I want to improve a little bit more next time. Then I wouldn't go back to C1, C2, JW4 or 5. No, we could go back again to JW1. I wouldn't do JW3. It could be, you know, 1 ml, 1 ml. It would have improved for sure. But take a look at the, this is what I would say. Take a look at the angry dog here. Take a look at the heaviness. Look at the heaviness here. So this is a lifting power of CK1 and CK4. You see, this is real, real, real. Okay? And take a look how the lower lip advanced with the chin. So this advancement of the chin is JW4, JW5. Okay? So this is a lifestyle photo that we took without the hairband to see. Take a look. It's interesting, right? This photo is like no swelling. This photo is more or less, I think, 5 hours after the treatment. I think more, is between 4 and 5 hours. Guys, no swelling, right? No swelling. So she wanted to look more contoured, less saggy and less sad, and this is her appearance immediately after. And the number of syringes that we use were 16. Now I ask you guys, my friends, is this a lot? No. Can you repeat? No, Mauricio, it's a miracle.
It's a miracle.
You see the point? It's a miracle. I know it can be expensive, I know. However, my friends, it is from a Because the patients, that's what happened before MD codes, right? People thought that we used fillers only to treat lines. But now we are putting together MD codes and Vycross together to make surgical results. You understand? I look at this patient, it seems for me that she had a mini lifting, right? Surgery, a little bit with blepharo, and come on, how much does it cost a surgery? And we can do this, something incredible. It is no scars, no downtime, So that's why I only do injectables now. You see, of course, because this is the value. The value is not, guys, by the way, anybody can improve the nasolabial fold, anybody can make lips bigger, anybody can make cheeks fuller, but you see, what you have to direct is to give an alternative to surgery to people. This is how I position the MD codes. But Mauricio, but MD codes is expensive. Say, come on, you're comparing with what? With fillers? No, it's not fillers. This is an alternative to surgery. You see? And then compare this with surgery. But the surgery is forever. Is there any plastic surgeon here? It's not forever. Come on. It's not forever. That's it. That's it. It's not forever. Not even surgery is forever. And you know something that I learned? Eugenia, let me talk to them. Is there anybody from Turkey here? Okay, I went to Turkey many years ago. And I always interview a lot of people, patients, to learn from them. And I had this lady that I look at her, she had precisely this, saggy cheeks, loss of definition, double chin, skin excess, eyelids, eye bags, and I look at her very gently, I said, she was for the tour. I said, lady, do you understand that you have formal surgical indication? She said, yes, I know. I said, why didn't you opt for surgery? Interesting, I was trying to learn. I said, no, let me guess. She said, then I asked her, are you not able because of downtime? She said, no, I'm retired. And then I said, are you afraid of scars? She said, no, I had already my breast done. Oh, you got afraid of anesthesia? She said, no, I also had my tummy tuck. Then I said, no, it was interesting understanding. I said, you don't have money. She said, no, doctor, I'm very wealthy. I'm rich. I said, please teach me. You know what she said? She said, listen, doctor. I said, yes, lady. Yeah, like a kid, right? Because I want to learn. She said, you know what I'm afraid of? I'm afraid after a surgery in the face, I look in the mirror and I don't like what I see. And I cannot get it back. And I said, thank you, lady. Now we can. You see the point? I think, believe me, this one day is going to be more expensive than surgery. You see the point? Because, and this is why what I'm trying to do is getting better. I'm trying to get better all the time. You see, all the time. Now let's see the case study. And believe me, I brought this case. I consider her very challenging. And guess what? I will use less syringes than all the cases I use now. This is reality now. Look, I have a case. Look, challenging. She's only 45 years old, only. And she's aged for her appearance. So what happens? My friends, this patient is so expensive. Do you understand the point? If the guy that I did in the morning to make him look like a top model, he used 16 syringes. The girl from yesterday, full treatment, how I do in my office with somebody that I have to make a plan. So this is how, what I presented to you, of course, it was for you to learn many different codes, as many as possible. But I'll give you an idea if this type of patient comes to your office and you have to make a plan dividing in four sessions. That's what I thought. Take a look. I look at her frontal, oblique, and full profile. The first thing is this. Her double chin is not that bad. Huh? Do you see? She has a skin excess, but it's not that bad. But you know why I am afraid of her? Because she has too much structure on her face. You see the point? She's wide here. She has good chin. So the case from yesterday was easier in that point because she had small chin with double chin. What I had to do? Big chin and project. In her, I can't. Because take a look, she has a deficiency that she has a very strong bizygomatic width. She's huge here, and she's very sunken temple. So can I do curve or top model look for her? Yes or no? Never. I will create, because look, the top model look would help me subsmash, lift. But take a look, I would create a temporal deficiency that I could never be able to fix. So what happens with my hands? Locked. You see? I understand that I can make incredible things in front of you, but I cannot here. I cannot. It's impossible. But I'm going to tell you what I would do in my office to make it look better. Do you know that I hate that, right? Remember I told you. Does she look better? Yes, but she doesn't necessarily look good. So I feel my limitation as well in delivering a result. Okay? It's real. That's why I brought her. Okay? If I wanted to give you a show, I would bring somebody different. But I brought her for you because occasionally we have this type of patients with good structure. So she has good, take a look, she has a big CK1, so I cannot lift her with CK1. She has also good structure, right? She has good chin. Her chin is not small, right? And she has difficult eyes, and she has this, guys, you cannot see here. This is the malar mound, you know, the festoon. You cannot see this because it's not three-dimensional, but this is also, I cannot do too much. So in my mind is CK1 anchor. You agree with me? Because 0.111 will not make it bulging, okay? I also need CK4, right? More posterior as I can. Do you all agree? Now, this woman is so difficult that without knowing what she wants, I have to make her come back, okay? So instead of going to temples, she will not see, right? They don't give value to the temples. So I have to make her see result. Where I have to go? CK3. Okay, so I will lift and I will do CK3. Now I have a problem. Her CK3. Can I do CK3 bone, yes or no? No, because she has bony. She's a lot of bone. Then I ask you, then I have two options of CK3. Should I do malar fat pad or SUF? Okay. So if I do malar fat pad here, she's going to be too much. So I have to go to what? SUF. Now my question to you is this. Should I do normal SUF or double the dose for SUF? You see? Because VoLift doesn't project. So, diagnosis, saggy cheeks, yes or no? With volume loss, yes or no? With big structure. Can I do Voluma? No. So I do the second, which is VoLift. Then I have a dose, which is 0.5. What can I do to improve the tear-trough transition without projection and volume? Double the dose. You see how I adapt to patient. Raise your hands if you understood it. So is lifting with CK1 anchor, CK4, 1 ml for CK3. I am sure she's going to come back, right? Because she will see an impact. Now, the first impact is going to be there. I expect her to be less saggy and less tired in session number 1. 4 syringes. CK1, 0.1, 0.1, 0.1. CK4, 0.7. CK3, 1 ml. Raise your hands if you got it. Good. 4 syringes, 2 per side. Now, I want her to come back in a second session. You know already, based on our case number 1 from yesterday, remember that the girl that she was 26 years old, she had a full improvement. So I believe that when I do CK1, CK4, she'll have an improvement in the skin excess, even if it's minimal. Do you believe that as well? Yes, she will have. Even if it's minimal, 10%, 20%, she will have. Now, session number 2, how she's going to see the impact? Where is the impact for session number 2, contour lower face? There is something that she will look and say, oh my, it's incredible what you did. Which code? C1. Salim, you're brilliant. C1. So if I only do C1 for her, only, she will look immediately CUC. So I will put C1 and C2, and she will improve the double chin with JW4 and JW5. So session number, you see, this is interesting. Session number 1, she's going to come back because I improved her tear trough. Tangible, visible. Session number 2, she's coming back because I solved this. Right? So this C1, C2, JW4, and JW5. Question to you. I don't want to spend a lot of money for her. Huh? Should I double JW4 and 5 or no? No. However, I will not be able to solve everything here. Do you agree? Yes. No. So there is another code that I can apply to improve the double chin. Which one is it? JW1. Excellent. So the next one is JW1. So I did session number 1, CK1, CK4, CK3, 4 syringes. Session number 2, C1, C2, JW4, JW5. Session number 3, I still have to go, then I go to JW1. Now I have a question to you. She's a woman with powerful structure, yes or no? If we don't take care, you see, if we don't take care, she's going to look masculine. If we don't take care. So can I widen her here, yes or no? No. So JW1, I have 2 options. Volux, bone needle bolus 0.5, projection, and JW1 Volux subacute cannula fanning. Which one is the one? Needles or cannulas? Perfect, because I will do, yes, that's it. And the triangle is small or wide? Wide. You see, you already are experts of MD. I will stop now. You're brilliant. You see the point, how the thinking process. So I start my session with CK3, sorry, JW1, right? Now, I'm happy. Then what I can do? I can do the other stuff. I can do temples, right? Because I still needed to improve more her tear trough, so let's do T1. Because guys, T1 for her, as I cannot, you know, I don't know if you know this, T1 is important to expand this mass as well, okay? We expand this mass with CK1 anchor, CK1 also curve, and T1. So I will stretch this mass. As I still need, I was thinking of T1 and TT1, TT2, TT3, right? Imagine I put T1 with tear trough in the same session. She's going to see an even better area. And then I finish with NL and lips, right? So average for her, I counted to do, I would say, I don't know if it's going to be an incredible result, but a tangible result with 13 syringes. Okay? That for somebody that you saw 16 in the morning, we see this patient, right? We're going to sit down. Did you get it? Okay. I'm going to work now. Oh, let's see what you want. You see, we are not going to do the homework, but right now, what page is this? Only 30. Guys, in the mirror, she's worried about her double chin, right? A problem. Right there, double chin. Number 2, glabella areas. Number 3, nasolabial fold. So she asks, contour, refine, and refinement. And then, in the photo, she continue with double chin, jowls, and nasolabial fold. What's my difficulty here? I have to start in the cheek. And she wants here, here, here. Okay? But I have to educate her. And she wants to look more feminine. So I be careful we cannot make her look more masculine. So how I avoid make her look more masculine with the treatment? Don't do JW1, don't do top model look, and make her rounder. Round. What's round? CK3, lips, you see? Curves, okay? Mauricio, so let's do curve here? No, because of the temple. You see? What I had in my hands to make her more feminine, I can't. Now, then she said, less angry, less sad, and less tired, okay? And I asked, where did you see it? She thinks she looks angry because her nasolabial fold and jawline. She thinks she looks saggy, jawline and double chin, and tied the tear troughs. She never mentioned cheeks, and I start with the cheeks. You see? So this is why I asked her to put in the mirror. What I do, I say, look in the mirror, put your fingers here. Do you think it improves? She said, yes. Okay, that's where we start. Okay? Guys, we are going to now proceed. I'm starting because we cannot get late. Guys, how many selfies we have? Okay, let me tell you. When we finish immediately, we take our selfies because you have a car or a bus, right? You have to leave here, okay? Which code are you reviewing them?
The first session, CK1?
Yeah.
Yeah.
Go to the first session
Okay.
with 1 ml Vol lift, okay?
Okay.
Perfect. So we're going to go to
So the blackboard, yes, okay.
Good, right. So as Maurizio said several times yesterday, repetition is key and it's important, and everyone's clearly been paying attention because Maurizio seems very happy with the answers. But let's go over it again. We're going to start with perfect. And CK1, we have two options for depth, but before we jump to depth, we're going to use what product? Perfect. And how are we going to address this case in particular? What device? Perfect. And when we use a needle, where is our target tissue?
I have to do this. Guys, I'm sorry to interrupt, really. They just told me I was going to let you go through, but they forced me. I have to do the planning like in 2 minutes, so I don't run in the injection. But guys, putting down our thinking process. Today, September 20th, 2022, and I'm here in Monaco with a 45-year-old female patient. Let's go through the planning. We start with CK1 anchor, injecting Voluma in 3 injection sites of 0.1. Then, with the 0.7 left, we go with CK4, also with Voluma 0.7, 0.7. Now, to make it visible, we are going to go immediately to CK3, SUF. I'm gonna use Volift here, and I have to be careful with the malar mound or the festoon, 1 ml. She's going to have a result, an impactful one already. Then, 1, 2, 3, 4 sessions. Also, syringes. Session number 2, we have the 4 codes, C1, C2, JW4, and JW5. We have here Volux and 0.7, 0.3, 0.5, 0.5. And I finish session number 2. So all of the sessions have to have an evident benefit. Session number 3, she already trusts us, right? Because she saw effect. And we are going to improve even more her skin excess and jawline with JW1, this time with cannula, 0.5, big triangle. And we go to T1, mass. So I have 1, 2. And after this, we can go to TT1, TT2, TT3. I like to put tempos with tear-trough in the same session. It's good. I have Volbella. And I have 0.2, 0.2, 0.1. And after this, half a syringe to bring economy, right? In the nasolabial fold. NL1 and NO2. I have here 0.3, 0.2. And so I have here 4 syringes. And I do lips, 1 syringe. LP1 upper, LP1 lower, LP6. If I need to make her even more feminine, we may even inject a second syringe, okay? So 0.2, 0.2, 0.1. My friends, so what we could eliminate to make these treatments more affordable, okay? We could eliminate temples, we could eliminate JW1, we could eliminate tear trough, but I would not eliminate after doing. So let's suppose I want to reduce the budget, okay? I would keep these first 8 syringes. Nasolabial fold would be my syringe number 9, and then lip would be my syringe number 10, if I want to bring more economy. I wouldn't be able to give optimal result in the tear trough, and I wouldn't be able to deliver an optimal under the chin. But with 10 syringes, it would bring a little bit economy of my patient. So this is what I would do to have an impactful result.
Maurizio, can I please ask for some clarification? You've written Volux for T1, but I suspect...
Oops. Oh, good. No, this is no. I'm so sorry. Redoing this. This is Voluma. Thank you for flagging this out, okay? Okay? It's Voluma. Thank you, Nestor. Okay. My friends, what you have to do now is only to observe if I follow the same method of the MD codes. If I forget something, oh, this doesn't count. If I forget something in the technique, you get a selfie. Okay? My patient is 45 years old. As we have done the plan, we are going to focus in session number 1 at the foundation midface and periorbital area. What is important for you to see is, take a look, the presence that we saw is more or less the same that we had with the angry dog session. It's the same area. Can you do this? Look. Look at me. Regardez-moi. Take a look. It's the same thing that, une autre fois, no, les yeux suivent le nez, okay? Angry dog. You see, this, my friend, is the same thing that we learned yesterday, right? Is repetition. Relax. So what we do now, we ask le menton vers le bas, les yeux vers le haut. We mark the transition of the lower eyelid. Now, I rotate, and she has a very powerful CK2. This is a powerful CK2 that I cannot inject. Take a look. Powerful. This is the eminence. And this is the area that sometimes the patients swell. So I have to get away from that after marking my CK1, and also when I'm going to do the SUF. So marking the upper margin, the lower margin, I palpate the suture 5 millimeters anterior and posteriorly. Okay, so I be careful with this anterior point, because depending, it can make this projection worse. Ok, allongez-vous, fermez les yeux. Maintenant, je vais commencer à... Ok. We start with... Un petit plus haut maintenant. Ok. It's with the first 3 anchoring points, my friends, that we try to check if our strategy will work. I have Voluma here. That has the, it has the rheology to provide lifting. I pinch and I retract and I inject where the black dot was. Touch the bone, aspirate. I inject 0.1. Never going through the marking. I practice to aspirate with one hand. So if you have small hands, it's more difficult, right? But we can practice. My assistant will remove. And let's see if something happened after injecting CK1. Est-ce que vous pouvez vous asseoir? Do you see any difference?
Yes, it's beautiful, Maurizio. We can see a nice lift and support to the lower eyelid as well.
Yeah, it seems that she's getting slimmer, right? And I also see something here, right? The same thing that we saw in the other cases. Fermez les yeux. The same thing, take a look. The bone structure looks softer now. Okay? The same thing. Okay? Regardez. Maintenant, sourire, s'il vous plaît. The same thing, the zygomatic is stronger. Take a look, the angry dog now getting softer. Also take a look, the wrinkling. Fermez les yeux. So, non, fermez les yeux. Arrête. Okay? The results after you inject CK1 has to be, the results, they have to be consistent. Now, let me explain this to you. She has a difficult CK4. She will hear a quick crack sound. I'll ask her to bite. Serrez les dents, s'il vous plaît. Then I mark the anterior margin. Relaxez maintenant. And I clean beyond the entry point. Clean, clean, clean. And I pinch strongly. Clean again, look. Enter with the introducer, circular movement. And I have here 0.7. Always as posterior as possible. Remember, 0.25, 0.25, 0.2. The more posterior we can go, the better. Now, we have to address CK3 SUF. And remember to massage. Okay? Only CK4. Don't massage CK3. Let's wait a little bit. Any question?
So there was a question it came in twice actually with regards to using a cannula and aspiration. Do you want to talk us through that?
Let me tell you, I never aspirated with the cannula in my life. So, because I think 25, and I try to go softer, has prevented me to have intra-arterial commitment. But I had friends, when they are doing lip, they told me they had an entered inside the superior labial artery, and it became whitish with a cannula. Okay? So it's really difficult to aspirate, you know, but as I usually use cannulas myself in the sub-Q or in the lip or sometimes temples, I never felt the need to aspirate. So if you ask me, I don't aspirate. Do you aspirate, Nestor?
I do not. My mindset is I'm continuously moving, so aspiration would be futile.
Yeah. So, yeah, I see people sometimes they injecting, aspirating. Let's see now. Asseyez-vous, s'il vous plaît. Is she getting slimmer?
Yes, very much so.
Excellent. Let's see. Sourire. Relaxé. Now we have to go with the... Fermez les yeux. Souffle. We mark. I have to mark, right? And I also have to mark the angry dog. Est-ce que vous pouvez faire... regardez-moi, comme ça? Non, non. Yeah. I ask the patient, yes, to mobilize. Take a look. Relaxé. This is a tricky region for us to inject, right? So now, take a look. It's almost everything. So I mark the souffle area. I have the festoon here, the Mailer bag. Mes amis, my friends, thank you very much. What I have to do now, right? So I will have to enter with a cannula, and I'll have to go, and mostly in the areas that are not red, but when I come here, I have no choice. I will have to inject as minimal as possible, but I planned 1 ml, which makes my life even more difficult, okay? So I have to go slowly. Usually, when I have difficulties like this, I put 0.5, massage, 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 then I put 0.5, okay? So I will remove this part to avoid contamination. Is it clear, the marking there?
Yes, very clear.
So we have, this is a point, right? This is real life. That's why sometimes people, they have bad results, because when I started, you know something, guys, sometimes I didn't know where to inject, but I always knew where not to inject. So this has prevented me to have unfavorable results. So I used to mark what I call the no-go zones, like the angry dog, the Mailer bag, right? I mark and I don't get there. So, clean, clean, clean. Pinch strongly, clean again. Needle in, circular movement. Oops. I'm starting in this free area that I have here. Then I go to the lateral part. Can you clean again, please? So when I went now I went through the zygomatic ligament. You see, I try to go more laterally as possible now, you know? Concentrating laterally rather than medially. Look, I already put 0.5 laterally. Now I'm going to put, I'm sorry, si ça fait mal, vous me dites. Now I'm getting to the south area, medially. So I put 0.2 in this mid part, and I'm coming back now. Sometimes I ask the patient to see the concavity. Ouvrez les yeux et regardez vers le haut. So I ask them to see if there is empty spaces. Fermez les yeux maintenant. So 1 ml. And then I remove the marks to check if there was the improvement that I expected. Asseyez-vous, s'il vous plaît. You see that I have to massage laterally now, okay? Cotton tip, and we massage. Sourire. Can you zoom in, please? Relaxez. Sourire un petit plus. Plus. Take a look the wrinkling in comparison to the treated and untreated side. Also, take a look how more powerful orbicularis ocula is. It's closing stronger than the left side. So this means that it became more powerful. Also, take a look at the angry dog. Take a look, less strong. Okay, relax, sourire. Take a look that now the sausage is more pronounced. Is it visible there?
Absolutely.
Freeze. Again, sourire. Freeze. Take a look at the difference between the treated and untreated sides. Okay, relaxez. So this is the indirect effect. So by injecting the SUF, we have more stability for the lower eyelid. And also, can you point with the laser pointer the Alequenase labii superioris and the angry dog on the left side? And did you see also that the right eye is much smaller than the left? Is it visible there?
Very clear, Maurizio.
Okay. So we are bringing back the best condition for our patients. Okay, and freeze. Now let's go to the other side. Marking. CK1. Fermez les yeux. No. Feel the suture. And we are going to, okay, s'il vous plaît. Clean, clean, clean. And pinch and retract and inject where the black dot was. Touch the bone, aspirate. So 0.7. Les côtés gauche, c'est toujours plus sensible. Serrez les dents. Ask the patient to bite. Relaxez-vous. And we proceed with CK4. Clean, clean, clean. Beyond the entry point. Pinch strongly. Clean again. Needling, circular movement. And always laterally. Gaza. The more lateral we go, the better lifting we will have. C'est la cric-crack. Now we remove the marks. And we massage. CK4. Goza. Okay. Any questions?
Well, there was a question regarding the entry point of CK3.
Okay.
Because you're using the same entry for deep malar fat pad, ZOOF, and tear trough. The question was why you used this one, and the other one was how do you decide where to put the entry point?
I think the entry point, you have to get the size of the cannula, right? So what I do is this. I get the iris. I draw a line downwards. Then I have the nasal flare at the nose, where this line from the lateral, or you can put even the lateral canto area, and the nose flare, you have an intersection of these two lines. This can be a very good entry point. So why I don't do many entry points? Bleeds, you see. I have to stop the presentation, show here. I have to stop because she's bleeding now. You see the point? So the more entry points, more bleeding opportunity. So that's why I try to use the same entry point for CK3, malar fat pad, ZOOF, and tear trough. Okay? Now, let's go to... And sometimes patients are bleeders. Okay? Now let's go to rotate. So we mark, regardez-moi, mid-pupillary line. And then we have here. And then we have the angry dog. Right? Relax. I mark the ZOOF. Vous pouvez fermer les yeux si vous voulez. And I remove this to avoid any contamination. You see, I mark only for you, but if we touch the cannula and the ink, this will bring huge contamination for the product, right? Remember that Vycross has the longest duration of any biodegradable product that we have. So we cannot contaminate. So clean, clean, clean. Pinch strongly. Clean again. Introducer in. Circular movement. So starting mostly laterally. So the ZOOF is divided into lateral ZOOF and medial ZOOF. C'est stérile, non? No, no. Okay. I don't like to even clean, but with the cotton tip, it has to be sterile to avoid any contamination. Clean. Non, avec un sèche. Okay, it's okay. I think from a technical perspective, this patient is tricky, right? Because I cannot go everywhere that I want. So I have to address the SUF. And now, fermez les yeux. We finished session number 1. She looking more lifted, also slimmer, and possibly less tired. Any questions?
So in case you would do there was one question, in case you would do the tear trough, would you do the temples first and then tear trough, or go directly now after treating the mid-face with the tear trough?
Let me tell you something. So I would say, let me tell you how I work in my office. Can you believe that I don't do any dangerous area in the first visit that the patient comes for the first time? I avoid doing tear trough in the first visit, temples, nose. I do really foundation to know the patient must trust me, because this area that they are advanced, like tear trough, temples, they have risk. So if I have an adverse event in a patient that already knows myself and trusts me enough, I can handle any complications that may have. So if it's a first time, the patients, I really avoid doing areas that they are more, I would say, complex and challenging, okay? This is my business. So I think you can have a really good result only by creating foundation and tear trough directly without the need of going to temples. So when temples become so important, because of the eyebrow. In her case, temples are not so important because the eyebrows are higher, good enough, you see? So you can skip it. So let's suppose if I wanted to do 5 syringes, I could do now tear trough as long as she's not the patient in first time in my office, okay? I would put it now before temples.
Okay, got it.
So, session number 2, we are going to work on the chin area. Can you zoom in, please? Look at me. Fais comme ça avec le. I ask the patient to invert her lip. Very far away from the lip. Remember, closer, it's better. Relax it. Sometimes, if you want to mark, even mark with the patients without putting the tongue inside. Sometimes for the marking, you know sometimes what I do this look. I see where we have deepening. If you remember her, she's easier for us because remember that we divide into 3, right? She's deeper laterally. So now it's easy, 03, 02, 02. Okay? Ici peut faire un petit peu mal, ok? Vous me dites. Relaxez la lèvre légèrement, non pas si tôt. Un petit plus, comme ça. Now we clean, clean, clean. Paint strongly, clean again. Needling, circular movement. So I start, look, going up, going down, going up, going down. Yeah. When it starts bleeding, okay. My friends, I hate bleeding, but when it bleeds, it bleeds. Now we go. Can clean, please? Clean more. Okay, good. So 0.3. Okay. Tiens. Pas beaucoup fort, hein? Très. Table plus haute. I think the C1 for her is going to bring an incredible result. Take out. A. So, clean, clean, clean. Paint strongly. Clean again. Needling, circular movement. Ouvrez la bouche un petit peu. OK. OK. Zero 0.3. Done. She's a bleeder, right? So, any question, guys?
Well, there is a question regarding C1. If you ever cross C1, or do you the midline?
Sure. You hold here. Let me explain this to you. We cannot listen. When we put really the midline, if you do not cross a little bit, you're going to have like a cleft. And this may impact the movement of mentalis. So when you're in the midline, you always do a little bit on the other side. Even when I do like JW5, it's the same. For males, we divide because we want to see the cleft. Okay? Sortez. Okay, let's go back. Non. Le menton vers le haut, plus que possible. Ça saigne, non? OK. So marking JW4 and JW5. So 0.5, 0.5. Clean, clean, clean. Paint strongly, clean again. So 0.5, so it is 0.2, 0.2, 0.1. Zero 0.5. Okay? Bitte. Okay. Let's go to the other side. Clean, clean, clean. Pinch strongly, remove. Clean again. Needling. Circular movement. So, very gently. What I think that what Volux brings to me here is really the sharpness. Can you clean there for me? Sabrina, can you clean? Go there. Yeah. Clean with alcohol, but don't put alcohol in the orifice. Okay. It's okay. Now 0.5, we push forward. So remember, after I remove the marks and I check from below. Le menton vers le haut. Salina, ici. Marking, cleaning, cleaning. And then we massage. Okay, dry gauze. Arrête ici, l'autre côté. Okay, while we make sure that the patient is not bleeding. Any questions?
There is a question regarding the codes. What exactly is the difference between C2 and JW5?
Good. Okay, first, both of them are Volux. Both of them are sub-Q. C2 is bolus, JW4 is linear anterior grade. Location, C2 and JW5. So JW5 gives support for C2, as if C2 lies on the top of JW5. So we see C2 from frontal view, but we don't see JW5. We only see JW5 when we chin up. Okay?
Okay.
Now, stop the bleeding. Now we're going to go to the temples, right? No, JW1 now, sorry. And we discussed that our JW1 is a very wide rectangle for lifting. We don't want any projection. The wider for us, the better. Okay? Ah non? Okay. Fermons les yeux toujours. So I clean not to contaminate. Clean, clean, clean. Pinch strongly. Clean again. Un petit plus bas, c'est comme ça. Needling, circular movement. Start then fanning as wide as possible. It's as wide as a CK4. And I will massage JW1. Okay, so I don't want projection at all. I don't want her to be wider in the bigonial width. Okay. Now we go to the other side. S'il vous plaît. Un petit peu, tourne. Vous regardez ici, okay? So clean, clean, clean. I will take out this part. Pinch strongly. Clean again. Introduce your ring, circular movement. Oops. It's okay, I'll go faster. Let me tell you what I ask the patients before a procedure like this, okay? Only for you, because she's a bleeder, right? Can you, I had to see. So, les deux. Let me explain to you, when I'm tour or even in my office, I ask them, pas d'alcool, no alcohol, no anti-inflammatory. There are some teas or caffeine that increases the heartbeat. Sometimes they are with tachycardia, they bleed more, high blood pressure. And women that they are in their period, they bleed more, right? So, you see, she's a bleeder, although she has not taken alcohol, she has not taken any anti-inflammatory, but occasionally does. So every time that the patient bleeds like she's doing, it requires for us like to stop the bleeding, because if I don't stop the bleeding, she's going to swell in one side, and then she can look like this, look, distorted, right? Even in the office. So they're going to be very bruised. So we have to see. And you see that I try to go faster and not to put gauze, contaminated gauze, to contaminate the cannula, right? We use a sterile stick, right? It's sterile. So my assistants, they take out, then they put sterile and throw away immediately. They don't do it twice with the same one. So we are protected against infection. But you know that this is a sort of cotton, and we don't want also microfibers of this cotton getting in with the cannula. So if better, I prefer not to dry or anything, like I did now. I went faster to avoid the bleeding. Okay? Now, and imagine if I didn't know what I had to do, and the patient is a bleeder, I would get really nervous in front of you, my friends. Now, let's mark the tear trough. No, let's go to T1 first, right? So, T1, we ask the patient to slightly open the mouth, relaxer la bouche, un petit mois. Maintenant, vous ne pouvez pas parler ou bouger, OK? Si ça fait mal, tu me montres avec les doigts. I ask the patient to show this when I ask, is it painful? If she does like this, it's okay. If she does like this, I have to go slower. If she talks, my needle goes. Sometimes I am with the tempo. I say, is it painful? The patient does this, no, with the head, you see? Or they talk. So, no movement. Fermez les yeux. So, clean, clean, clean. I have volume. I retract, needle in, touch the bone, then I count. 1 and 2 and 3 and 4 and 5 and 6 and 7. And then the injection, my friend, has to be very slowly. The patient must be relaxing the jaw. The slower, the better. It's normal to the patient to feel pressure, irradiation to the teeth, but not pain. OK? Change l'aiguille. Tiens. Pas si fort, hein? C'est doucement, c'est doucement. OK. Take out. The same thing, the left side is more, can be more sensitive. Retract, support, needling, touch the bone, aspirate. And 3, and 4, and 5, and 6. Si ça fait mal, vous me dites avec les doigts, OK? What is important is the patient has always to be with the mouth relaxed. Let's suppose if my hand, for any reason, changes position, I aspirate again. So let me tell you, temples we have to hide because look, hold here for me both. She's a bleeder. Maybe we don't see blood, we don't, superficially, but she can be bleeding deep. Let me share with you the entry point. Can you rotate? Can you zoom in? Take a look at the entry point for T1. Is it visible there?
Yes, Maurizio.
We can see it.
Okay, so this is the entry point for T1. Oh, this is still bleeding, so you can see it. Okay? It's very close to the symbiont. Ça fait mal?
No.
Okay.
Maurizio, could you describe the anatomical location of T1 and maybe T2 for
Yeah.
our delegates to understand better?
So, can you hold this? Can I show it after? Because I don't. I will show in the skull. Okay.
Perfect.
Remind me. Let's go here. Is it still bleeding? Okay. Let's wait. Ferme les yeux. Obtiens. Ferme les yeux. OK. Ouvre. Regarde-moi. Retire. So now I mark TT1, TT2, and TT3. One, 2, and 3. Ferme les yeux. So I go to the entry point, and the entry point is the same as the CK, and I go and I rasp the bone. Clean, clean, clean. Oh, I have also to show you the micro-aliquots, right?
Yes. Yes.
Yeah. So 0, 2. Another 0.2. And we go with 0.1. Sorry. The patient feels rasping the bone. It's not a nice sensation. So, and if I need to go more medially to the medial canthal, I do this with a cotton tip. So I don't take the cannula there. Although you can go, but we don't need. Volbella is so movable. Okay, after I will massage, okay, guys? I promised we had to stop on time. We have to, right? So 0.2. We have to put EMLA on lips. 0.2. And go 0.1. Excusez-moi, je sais que c'est sensible. Okay. Why we put some cream on the lips? Ouvrez les yeux, s'il vous plaît. Maintenant, regardez-moi. Faites comme ça. Okay. So my assistants will massage, okay? And I will, tiens, I will show you, get me a sample of Voluma with needle and Volbella with cannula. Markers. So, the temples, where are we, right? We feel the fusion between the frontal and the temporal bone. Then we have here the lateral orbit. And T1 is immediately where our finger forms down. And T2 is like 1 centimeter more posteriorly. What is the issue here? The deep temporal arteries, right, that we don't know precisely where they are. So that's why going higher is the most important thing to avoid any risk. That's why this is an advanced area. So we get here, you see myself retracting, I put down to the bone, I feel the bone, I aspirate, and I don't move. And I inject a bolus of 0.5. Okay, so we have to aspirate. I don't know if it's visible.
Yes, we can see this clearly.
So I don't, you know, as we do not know precisely where the deep temporal arteries are, we have to make sure that there is no positive aspiration. Now, when we go to Volbella, you know that I mark, right? 3, always like this, right? I'm marking, marking, and marking like this, right? So in reality, can you zoom in more, or should I go? So it's not doing, so what I don't do this, look, 0, 2. This is wrong. What I do in TT1, TT2, TT3 is this, micro aliquots. Can you see this? Is it visible?
Yes, we can see them.
It's a group of aliquots, that's why we call micro aliquots, whose total is 0.2. So I come here and I'm moving the cannula, look, 0.2, 0.2, and 0.1. Okay? This is the way I found that we reduce tyndal and edema. Because in the past, I thought that Teotrof should be injected linear like a sausage. So this is completely wrong. Can you zoom in? If you do like a sausage, right, you will retain more water and you are going to have a very Tyndall effect. So doing microaliquots is the way I found to have less adverse event with the injections. Okay?
Perfect. Thank you.
So what is challenging, guys, is to ensure, what is challenging is to make sure that you distribute the microaliquots. You see, if you have to, if you don't practice, you know how I practice? I got a 1 ml syringe, I put saline and I put 30 gauge needle and I started testing my thumb, you know, with water. You don't need to spend money with the product. Do with water. And if you're able to do this with water, you will be able to do this with a cannula. Or saline, right? Now let's go to the nasolabial folds. So clean, clean, clean. Oh, by the way, do you know this type of lines that we have, static lines? This is excellent for volite. This is volite, you see? Volite, volite. This is the secret. I don't expect to eliminate this with a treatment of the nasolabial fold. Because this is, can you sourire? This is where the muscles, you know, they pull the corner of the mouth. So we have to thicken the skin with volite. Okay? Relaxez, s'il vous plaît. So I don't expect improvement at all in the nasolabial fold for the lines. I start with NL2 injection to reduce the pain because then close to the nose is the most sensitive area. So here, 0.2, then I advance and I start fanning with 0.3. I like very much to put nasolabial fold and lips in the same session. You know why? Because now I have the anesthesia of the infraorbital nerve, right? So it reduces the discomfort. S'il vous plaît. Clean, clean, clean. Pinch. Needling. Clean again. Sorry. Circular movement. So 0.2 NO2. And now we fan. Now, as we finish, we're going to the lips. Maintenant, je vais injecter le lèvre. Ici peut être un peu sensible, OK? Vous me dites si the speed is too much. Tournez là. So, clean, clean, clean. Clean again. Oops. Yeah. Yes, good, good, good. Clean again. Just a second, I have to purge. Purge. Give me again. That's okay. When I want to bleed, it doesn't bleed. Ouvrez la bouche un petit peu. Si ça fait mal, vous me dites. Hein? Zero point 2. Zero 2. And 0.1. Let's go to the other side. Okay, Alexa, s'il vous plaît. Clean, clean, clean. Pinch. Clean again. Circle in. Yeah, now clean again. Gauze, no. Gauze. So let me explain what to do now. It's bleeding, right? I have to wait a little bit. I have to press more to stop the bleeding, okay? The gauze is clean, but it's contaminated. Now I ask my assistant to clean 3 times. Okay. 1, 2, 3. Then I can try to, now it's not cleaning anymore. Okay, now I found it. Ouvrez la bouche. The problem is when the patient bleeds, contamination. So 0, 2. Trying to stop the bleeding, we contaminate. Sorry. Now 0.1. Done. Everything that we promised, we delivered. Okay? Now remember, I have to massage, fix here, this one. Ouvre la bouche. Rafa, how good or bad are we with time? Ouvre la bouche. I still wanted time for questions.
Right, we have a little bit, I think.
No. What time is it?
3:30.
Good. So we're going to finish at 4, right? That's what we...
Yes.
This is what we need, right?
That's right, we have half an hour.
Good. Excusez-moi, est-ce que vous pouvez rouler les lèvres plus? Non, j'ai presque impossible. OK. Une autre chose, regardez-moi. Vous pouvez faire comme ça, pour me dire si vous pouvez sentir les produits. Non. Une autre chose, je vais désinfecter votre main maintenant. OK? Et vous devez me dire si vous sentez, si vous pouvez sentir les produits désinfectés. OK? Donnez-moi la gaz. Yeah. Sécher. OK. Ici. Maintenant, chaque fois, les pommettes avec les deux mains, avec le doigt, oui, comme ça, très gentil, très gentil. Est-ce que vous pouvez sentir les produits, oui ou non? Non. Non, ok. Et ici, non, le menton, est-ce que vous pouvez sentir?
Oui.
Ok. Et quand vous sentez les produits, ça c'est tendu ou pas tendu?
Non.
Okay, I ask, is it hard or soft? She said, it's souple. Okay, so she said, it's not hard. So,
C'est souple.
souple. So, demain, cette région sera tendue et ça fera un petit peu mal. Ok? Est-ce que vous pouvez sentir les produits ici?
Non.
Non. Mais quand même ici, un petit peu tendu. OK? Et ici, les signaux, est-ce que vous pouvez sentir le produit?
De ce côté-là, oui.
OK. Et ici, sur les lèvres.
Oui.
OK? So, on espère que demain, qu'ici soit tendu. So, we only wait this, we expect to have been sensitive only in the chin and the codes that we put for JW3. Can I see, please, Saline pour Massé? Can I see her photos of her? And we have to fix the hair. Réglez-le. Massé, Massé. Fix the hair a little bit. Okay. Okay, let me give me a gauze. Ne bouge pas maintenant. Freeze. No. Unfreeze. No. Freeze. Okay. You can show the result.
Amazing.
Unfreeze. C'est bon? Le résultat est mauvais, c'est bon? OK. OK. Dites-moi maintenant, Eugenia, can you put her photos before again? Où est-ce que vous pouvez voir la différence, s'il vous plaît? Où?
Ou là.
OK. Plus, can you increase the microphone so I can hear? Où est-ce que vous pouvez voir la différence?
Sur cette partie-là.
OK.
Ici aussi.
OK.
Et là.
OK.
Et les lèvres,
Les
évidemment.
lèvres. Pour vous, qu'est-ce que vous préférez?
Qu'est-ce que je préfère?
Oui.
Le fait de revoir la pommette dessinée avec l'ovale du visage. En fait, ça fait quelque chose de, comment dire, d'esthétique et d'harmonieux, quoi.
She said the cheeks and the jawline because it's more harmonious. OK? Est-ce que vous pouvez me décrire cette transformation parce que je peux comprendre? Pourquoi tu es comme ça, like this? Émotionné? Ému, pourquoi?
Parce que je pensais pas, puis du coup, je vois moins mes cernes, je pensais pas que c'était possible.
Ah, OK. Because she said that she never thought it was possible to improve the tear trough, le cerne?
Ouais.
Ici, c'est
Ah oui,
vrai?
les cernes, c'est vrai.
C'est vrai. OK. Merci beaucoup.
Merci.
Maintenant, fermez les yeux, s'il vous plaît. Maintenant, je sais que c'est très difficile pour vous. Essayez de boire un petit peu de l'eau, très légère, un petit peu. OK? C'est possible?
Oui.
Regarde, la dernière chose, regarde et say bye-bye with a beautiful sourire. No, with the done. And freeze. Okay. Good. Les yeux sont devenus encore plus. Okay.
Great.
So we appreciate there's been many questions that have come in, both online and via the app. Maurizio will certainly endeavor to answer the more pressing ones, and he certainly allowed time for that.
Just waiting for Maurizio.
We'll start going out into the audience.
Wow, it was good, huh? Yeah. You see, this is what impresses me when they see themselves. They have, you know, what I noticed is, I don't know where you're from. I don't know. But I don't know if she's from Monaco or from France or certainly from Europe. In Brazil, we know this exists, you know? Everybody knows because we are very cosmetic oriented. I think Latin America, Mexico as well, you know? We know it exists. In Europe, no. It's incredible. Where is aus Deutschland here? One of the worst countries that I see that have no awareness is Deutschland. You know, Switzerland. You see, what happens is this. Every time that I see that a patient gets surprised from what we can do, right? I got astonished because they have no awareness. So that's why I tell you, my friends, I try every day to get better and better to promote this to people. And I think this happiness that we can deliver to her and the ability that we can make somebody happy is what I, together with Allergan Medical Institute, we are trying to expand to all of you. You understand? Because as I told you, I don't know if you know, I was talking to her before the event. I was saying, do you know that I love when you smile? She said, you know, Maurizio, when I was younger, everybody always talk about how beautiful my eyes were. And nobody mentions that. That's why I think when she saw it, she got emotional. Because she was not expecting something that she has lost. Imagine, everybody say, vous avez de beaux yeux. Your eyes are beautiful, beautiful. One day they stop saying that. So you see, the best thing that you have is gone. And you think that never in your life you will get it back. And now she got it back. You see, that's why I think that's the impact. So, the first thing I believe for us to get here is to get technically better, right? So, as I told you, what I can do now, over 25 years of doing this on a constantly basis, and in the past, since 15 that I started the MD Codes tour, I'm getting better because I'm practicing. You see, it's just like going to the gym, it's just like doing the piano. It's impossible, like, to achieve this without practicing. So it's feasible. It's feasible. And now with the MD Codes, and together with this, right, you see, we put 13 syringes with her. I don't know if you noticed this. She got emotional. She smiled. She cried. Natural. You understand how crazy it is? I think you have seen already many people being injected. They look weird when they express themselves. And this is a property that I always relied on Voluma, Volux, Volift in the lips. So that's why each product has a specific G prime. G prime is the gel hardness. Imagine if I had put something harder here now, when she would cry, instead of crying like this, look, they would cry like this, look. It's weird. You see the point? That's why this became, for me, the tool for me to take the patients to the next level. And we cannot forget that. We have any more questions?
Not right now.
No, right? We have more questions? No, if you have more questions, you can ask. Yes, do it. No, can you get the microphone?
I ask what's the difference between the C6 and M1, M2, M3?
Perfect. Guys, let me tell you this. Very good question. Layer. The region is the same. C6 is a triangle in the lateral chin, and marionette lines are lines that form because of lack of support in the lateral chin. So if I have marionette lines, I have options to treat. I check if there is a deficiency. So C6 is the same region, but injected fanning in the subcutaneous support. And M1, 2, and 3 need those dermal. So you have two approaches for marionette lines. But let me tell you something. Do you know what is the most expensive area in the face? Marionette lines. Why? I will explain to you. You see that we may be 20 years old, we can have nasolabial fold, we can have crow's feet, we can have glabella lines, but we don't have marionette. So marionette is the tip of the iceberg of many deficiencies. First, the chin sometimes is normal, but we know we have bone reabsorption over the years. So the chin gets backwards. Secondly, the cheek falls down. So the marionette is a result of a saggy cheek and the chin that lacks the support. What else? I am young, even having thicker lips. Over the years, do you know this? Everybody will have thinner lips, and when we are 90, the lips will disappear, right? So what happens? Marionette also is a result because of deflation of the lip that deflates the oral commissure that causes the marionette lines. And another thing is the occlusion of the teeth. If I am overbite or deep bite, I have the upper maxilla foreground and the mandible backwards is another cause. So that's why if I try to compensate marionette lines with M1, M2, and 3, you saw this. The patient gets big, like a bulldog, heavy, and they look weird. Do you see the point? So that's the difficulty when the patient comes to me and say, oh, my first area that I want to treat is marionette lines. I have to go for education, right? And again, in my face, as I tell you, everybody would agree, I think marionette lines and double chins are the worst two aging signs that we hate, right? So crow's feet is okay, nasolabial fold is okay, thin lips is okay, but marionette and double chin, bad. And both of them requires a multi-area approach. If it was easy, you know this, guys, you've been injecting at least for 5 years. If it was possible to put half a syringe, we wouldn't be here. You see, do you understand? We are here because patients, they want us to solve complex things with one syringe. You see, that's why consultation is important. That's why we have to get a loyalty and partnership with our patients. They must understand that there is a journey to go. And some patients, I'm sorry, they want a quick fix, and they will go to cheap injectors. They will go to get this, and we cannot do anything. Our patients are those that understand what we can do for them. This is the difference that I tell us. So when you use MD codes, explain to them their journey. And you see, try to collect loyal patients. Can you get the microphone?
Oh,
No. Can you put you have only one microphone?
We have just one.
Sure. 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 Can you get me a flip chart, please? I'm sorry. I will explain about asymmetry. Okay? So do you saw that everybody is asymmetrical, right? Everybody. But I tended to put every patient the same quantity. I only correct asymmetry if the asymmetry is over 30%. What is 30% of asymmetry? Something that say, oh my, this person is very asymmetric. This is asymmetry, which is different from dynamic asymmetry. Dynamic asymmetry like this, somebody that smiles like this, is much harder than static asymmetry. But I will explain the rationale. I don't like patients that they have been treated in another place before they come to me. I don't like it, right? I don't, because there are mistakes. I don't know what happened. So if we can wait or if you can get rid of the product, this is an option, okay? But think, do you have a paper to write or no? Yeah. I will put a principle that I learned with breast implants, and I brought this to the MD codes, only for you guys to start thinking. Only think as a concept, okay? And now you understand why the cheek became so popular and replaced the nasolabial fold. You see something, patient likes more when we treat this than when we treat this. You understand now why. Let's suppose this is the right side of the face, okay? And this is the left. I'll give you easy numbers for us to think about math. Let's suppose that I have volume 100 on the right-hand side, and I have 110 on the left. I may say, mathematically, that the left side is 10% bigger than the right. Do you agree? I will inject the same volume. Okay? This becomes 200, and this becomes 210. Now, the percentage difference drops down to 5%. You see, that's why three-dimensional augmentation reduces the asymmetry. So what I do smartly, I see somebody asymmetric. If it's not dynamic, dynamic is another stuff. I try to use the same volume with the concept of 3D expansion. And then I use less. Now tell me the percentage that I correct. Take a look how everything is mathematical in MD codes. You have seen me injecting CK1, 0.1, right? This equals 0.3. Then I put 0.7 in CK4 or T1, then I have 1 ml. My question was always, if somebody is asymmetric, how much is this asymmetry, right? My question is this, should I correct this with 0.1, 0.2, 0? I don't know, right? Because it's this. So what I thought, only for you to understand the thinking process. I have the right side and the left side, and the person is asymmetric. I cannot correct for 50 to 50. Do you understand? Because this is the same volume. And then I thought, what is the ratio that I put in the more deficient side? I put 60% in one side, and I put 40 in the other. Then I came up, you know what? If what is visible is 30%, let me create the ratio of 70 to 30%. What does this mean? Okay? So this is my ratio. So I'll give you an example. Static, very severe asymmetry, cheeks. Okay? Very severe. I look is over 30%. What do I do? Step one. Start with the same one. Okay? I do, let's suppose, CK3 right side equals 0.5 ml VM, right? If it's asymmetry, it's not because of SUF. Then I put CK3 left 0.5 ml VM. I reduce the asymmetry. Step 2, we consider that the left side, okay, left is the problem. I correct CK3 right 0.3, right? Then CK3 left 0.7. You see? Then I correct. So you don't need to look, because if you have a thinking process, you guarantee that, right? So all the time, because guys, having 100% of asymmetry is impossible and is not attractive as well, right? Any other question? Yeah, please.
Thank you. Does your approach change when you're treating a patient that recently had a retidectomy or a deep plane facelift or something?
Sure. Let me tell you what my experience with patients that had had surgery, okay? For me, let me tell you something also that I learned. Say, Mauricio, let's see I treat you today and you disappear for 1 year. When I look at you, I see you as a new person. So I forget what I have done. I make the diagnosis, what you present there. I work with all, my head is all algorithm focused. I think you're going to receive, I think they received the algorithms, right? In the workbook. So let's suppose somebody has retidectomy. It cannot be less months, right? It has to be like 6 months, 8 months, whatever. And then you say, what are the diagnoses? What do I see? Lack of projection in CK1, lack of volume in CK4. I treat as a patient without surgery. What's the problem? Technique. It's more difficult. So what I found difficult, I tell you, patients that they had already surgery for CK4. Patient that they have the threads, more difficult. Patients that they have ultrasound, more difficult. Patients also that they have this biostimulator for collagen, it's more difficult technically. Even if I treated with AJ, when I go back, it's more difficult because we have fibrosis, right? Now, blepharoplasty. This is an issue as well. So this is an area that usually retains water no matter what. Sometimes we drink with no treatment, with no surgery, we swell. So sometimes we cry and we swell. So what I ask the tear trough area, when you wake up usually, do you swell every day? Answer yes or no. If the person says yes, alert. When you drink, yes or no? If they say, oh, every time I drink, I swell. You see, that means this person, when I put high hyaluronic acid, will swell. Now surgery in blepharoplasty, we change position and lymphatic drainage, right? So the patient cannot be seen as 100% normal. So what I try to do is always compensate indirectly, and I take very, very cautious when I'm distributing the microaliquots. Because usually, you know this, right? As an adverse event of surgery is hollow eyes. So the patient has eye bags, and then you have, in the past, we used to do aggressive bags removal. Now they have skeletonized eyes. And these people are very challenging to treat because they can have like edema. So what we have to do is the same that I showed. You know, you give support in malar, SUF, and then the tear trough. But don't do tear trough in the same session. try to see if the patient does not swell with the SUF. If they don't swell, then you go for the tear trough. And another thing, guys, is this. There are what I learned over the years is there are patients that's not worth treating, right? Because they are going to go to complications. I said, no, this is not for fillers. You know, so but when we are younger and starting, we don't know if this works. And that's why we get bad results. Yes, please. Here, you have another one?
I had
okay.
a question up here.
Guys, it's
Hi,
the
thank
two
you.
last questions, okay? Yes, please.
Okay, may I have some suggestion about CK5 when you use it, and it could be useful for the patient of today?
Which one? This one?
Yeah.
Yes, I thought about her, yes, as well. So what is CK5? Okay? CK5 is a volumetric code. Okay? So what happens? I usually associate CK5 after doing CK1, CK4 to lift, CK3, and then CK5. I thought about her, and I thought also doing CK5 in the male patient because of the dimple. How do I mark? The CK5, for definition, is submalar area. I asked the patient to do the fish, like this, look. The fish is to increase intraoral negative pressure. It's sunken. I mark it. I divide it into two, posterior and anteriorly. If you go too anteriorly, they bulge. So I enter and I fan 0.5 in the subcutaneous. I put my mouth, fingers inside and massage. And then is this, okay? She would be definitely a candidate. Last question.
Mauricio, thank you so much for your nice presentations. I have a question about the tear trough, because you do your job is very excellent for the valley of the tears, but the patients, in my opinion, they have still the dark circles. And I'm ophthalmologist, you know, so don't you think that if you take an entry point a little bit upper, so you can go on sub-albicularis and treat the circle darks better?
No, I think the entry point is always, as entry point is the area that you feel more comfortable. As long as you get into the direction, is yes. When you put, do you put deep or more superficial?
When I take, you know, I have an entry points,
Okay.
not on the lateral, in the middle,
Sure.
and then I will be on the periost, yes.
Sure,
And I
sure.
can do it, drop by drop, and I see very well, because when you go in
From
your
below?
entry point, you are in the layer, you never know where you are,
Yeah.
in my
Sure,
opinion.
yeah.
Okay?
No, you're right, but let me explain this. So as I use the same entry point for CK3, malar fat pad, SUF, and tear trough, I learned to do this. When you go, you can go higher to get directly there. What I think, as you mentioned, what is difficult is to go lateral. I see sometimes people trying to do the tear trough high and lateral. What happens? Because of the convexity of the cheek, the cannula goes up, and it makes more superficial and gets tyndal. The entry point, I think, is something, as you mentioned. What you find easier, the important thing for me, the tear trough, is get down to the bone and do microaliquots. Even if it's a high, it's good. It's good.
Yeah.
Okay? And the dark circles, what I find difficult is this. I never promise that they're going to become lighter. Of course they do. It's just like a balloon, right? So let's suppose a balloon is dark blue. You inflate, it becomes light blue. But I don't promise, you see? But they usually get it.
No, I mean, I told you dark circles, but I mean the hollow.
The hollowness.
Yeah, because when you do very well, the valley of tears,
Sure.
you know, the circle is becoming worse. That's the problem. So I think that we should do very well the circles also, because if not, it will be,
Okay, thank you.
Thank you.
Thank you very much. My friends, it was a big pleasure. I could not answer all the questions, so I received the list. We have the list. I usually post in my Instagram videos with answering the question that I have on tour. And if you have like this, just, you know, you're gonna see that. My final advice is this: it's worth. It's worth, you know, doing this and getting better. And my last message is, let's put our hands to work on the benefit of our patients, even if sometimes they don't deserve. Bye-bye.